Good morning, everyone. Welcome to the UBC Learning Circle, hosted by the Center for Excellence in Indigenous Health. I'm very pleased today to be joined in circle by Alexa and Cathie Wilson. They both agreed to join us today to share a bit about the Gwa'dzi Managed Alcohol Program, chat about their experiences with the program and all that good stuff. So I'm really excited. Before I get into anything else, I would like to acknowledge that I'm zooming in from the traditional and ancestral territories of the Comox First Nation. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle, letting us have these conversations. So a gentle reminder here today that the topics we cover can sometimes be sensitive or emotionally triggering. If that's you for today, please make sure that you're looking after yourself. If at any point you feel that you need to talk to a friend, elder, family member, or a counselor, please make sure you're accessing that support network. So introductions. My name is Cole. I'm from the Chalathil First Nation, and I'll be facilitating the session today, sharing our digital space, but off camera is Cynthia, our production coordinator. If you feel so inclined, please introduce yourselves in the chat box, kind of get that conversation going, and we can get started. With that, I'm going to pass the mic over to Cathie and Alexa.
Thanks, Cole. So my name is Alexa and I'm a settler of Scottish and Irish descent, originally from Montreal, and I'm the team lead and one of the registered nurses for the Gwa'dzi Managed Alcohol Program. And we're tuning in today from traditional Kwa'gilt territory, but work for the Gwa'dzi First Nations.
My name is Cathie Wilson, and I'm a settler from the Philippines. And but I was adopted by an elder here at the Gwa'dzi community and have been part of the community pretty much since 1998, and I'm quite immersed in the culture and the community and the families. And I'm the outreach worker for the Gwa'dzi Managed Alcohol Program.
All right, so I'm just going to share my screen right now, so give me 1 second. All right, so everyone should be able to see that. So again, Gwa'dzi Managed Alcohol Program, and so we work for Gwa'dzi First Nations. We operate on reserve here on Gwa'dzi Reserve, and work out of the Community Health Center. We are partially funded by First Nations Health Authority, who were the first group that did agree to fund us, and secondly by Island Health as well. So Gwa'dzi is the Kwa'gilt term for Port Hardy. So our program and Gwa'dzi Reserve are at the northern tip of Vancouver Island, and we obviously called the program the Gwa'dzi Managed Alcohol Program to make sure that it's pretty self-explanatory to folks about the program that they're accessing.
Yeah, even though we are located on the Gwa'dzi Reserve and managed out of Gwa'dzi, we actually provide service to all of Port Hardy and the surrounding nations. So there are 3 reserves or 3 nations that are quite closely attached to Port Hardy: Kwa'gilt, Quatsino, and Gwa'dzi. And we provide, our service is able to provide service to those nations and to Port Hardy proper.
So essentially anyone that we can access by car within about 15 minutes. Most of our clients are very high needs, and we see them multiple times a day. So it is quite important for us to be able to reach them rapidly if there's an escalating crisis at any point. So seeing folks in Port Hardy and on reserve, the multiple different communities around here. I guess the origins of the community here and why a lot of the trauma resulted is that in 1964, the federal government forced the Gwa'dzi First Nations from their original home. So if we return to the first slide, we have here a picture of circled in red the traditional Gwa'dzi Managed territories, with most of the community members coming from either Ba'as or Takush. And so in 64, the feds forced the Gwa'dzi Managed communities to what is now Gwa'dzi Reserve. And at the time, it was never their traditional territory. It was actually a Kwakiutl summer camping site. And so still to this day, that does, there's a lot of trauma and a lot of ongoing alienation, and that the community is still forced to live where their land is not. There were only about 3 houses, and when they first arrived here, which were really kind of ramshack buildings, like no plumbing, there was no medical services, nothing of the things that they were told that they would have access to when they came here. And a large percentage of the community died. So we still, in the clients that we serve here, and in most of the elders that still live in community that are Gwa'dzi Managed, they likely grew up in Ba'as and were moved at that time. So everything is still very, very recent in definitely that separation that's still ongoing. So the picture here at the bottom that you'll see is the one bridge that enters Gwa'dzi Reserve, and it's a bridge over a rapidly flowing river, and a river that does surge and swell when it rains a lot, which obviously Vancouver Island, it rains continuously. And in developing the managed alcohol program, there was, it happened pretty rapidly. At the beginning of the COVID-19 pandemic, we, as a community, went into lockdown really quick. And that was, we had the first cases on Vancouver Island, I think in probably the beginning of May. And so beginning of April. So mid-April, the community went into lockdown and instituted a very strict entry. Yes, there was a checkpoint at the bridge. It was very strict in that there was no one to enter or leave community after hours, which was about after 9 p.m. And this was to minimize the foot traffic across the bridge. And the assumption originally was, in mirroring what other communities were doing, that after hours, unless you're going to work, you should be at home inside. And so we were having daily conversations with elected chief and council about the COVID-19 updates. And as soon as the lockdown commenced and there were folks manning the bridge, we had a number of close calls with community members trying to swim across the bridge or try to swim across the river, or walk across the river at some of the low points. And we had some very close calls. There were search and rescues that did have to, teams had to be called in to help find community members that had attempted to cross the bridge to get what they needed in the town of Port Hardy, whether it was that they were suffering from alcohol use disorder and needed to access alcohol, or if there were other substance use disorders or struggles on board and that they needed to access, whether it was alcohol or drugs on the city side or the town side. So there was a lot of close calls, and at that point, elected chief and council started to discuss with the hereditary chiefs and matriarchs of the community to see if there was a better way to do this and what we could do to help those individuals and those community members. In a community that wasn't necessarily historically big harm reduction advocates, it was almost an overnight 180, in that it was very obvious that our community members were hurting. They had needs, and those needs needed to be supported, and we had to find ways to better be able to cope with COVID-19 while still not forgetting our community members that suffer from issues of either alcohol or substance use disorder. So there had been in Port Hardy at that point some conversations with different folks from either the Salvation Army or the hospital about harm reduction programs like managed alcohol programs. And our health director, Dean Wilson, brought that up to both elected leadership and hereditary leadership. And it was like, yes, let's do this, all on board. Let's get started immediately. And so Dean was able at that point to touch base with some of the physicians in Port Hardy. In Port Hardy, Maine, there is a small rural hospital that is, you've got the same doctors that work also at the primary healthcare clinic. And they were definitely open to it. One of the physicians, Dr. Sophie Waterman, was even more interested and decided that she was okay with spearheading that request and that push for funding. So once we got her on board, Dean was able to go to First Nations Health Authority that immediately okayed it, whether it was going to be kind of a, we could use the COVID-19 funding at the beginning and then it could move into something else, was somewhat up in the air. But it ended up being that we were able to get funding pretty much automatically for a 2-person managed alcohol program. So that was, I was working as a community health nurse at that point, and Cathie was working at mental health and substance use. So we got the funding and we started essentially asking other managed alcohol programs around if they could send us their paperwork or their sheets. We did a lot of reviewing of the Canadian Managed Alcohol Program studies. And if there's anyone listening that is interested in starting a managed alcohol program, I will say that it is quite easy to get other MAPs to send you all of their paperwork. I think that we're all pretty big harm reduction advocates, and we'll send you everything that we have if that's going to help you start a MAP or a hybrid harm reduction program somewhere else. So we got the jobs and started.
We had a lot of support from community. Like Alexa was saying, there were conversations already that started with Salvation Army 2 years prior to the pandemic happening, and also one of our other doctors. They had Michael, the executive director of Salvation Army, and Dr. Lee had traveled to Ambrose Place to go check that out for a promotion or a fact gathering trip for the district of Port Hardy, because the district themselves was trying to figure out what other services could be provided in community. So the conversations have already been starting in community. It's just many of our First Nations here locally hadn't quite embraced the harm reduction philosophy. And then prior to, like in March of 2020, there was a young lady that had been trained to the not just naloxone training, and she provided this in community. And our elders, there's 25 community members that had participated, and elders attended, and members of council, and some hereditary chiefs had also attended. And so when this conversation actually had to happen for the community, it was easier to embrace it because they'd already had that introduction to harm reduction. And then we also already had the foundation laid with the bigger community of Port Hardy, with community partners such as mental health, harm reduction, mental health and substance use services, the hospital, Discovery Youth and Families, and Salvation Army, and the RCMP. So we had a lot of support already going into this. And then when Dean came to the community and said, we'd like to start this, it was, yes, we will do whatever you need to get this up and running. And then so it was just that it was an easier ask to FNHA then at that point to say, hey, we have a lot of support. This is what's absolutely needed in our community, and this is how we can make it happen. So it was a fairly quick process for Gwa'dzi Managed Health and Family Services.
So at that point, I mean, we started asking other MAPs for their paperwork, what they do. All we knew essentially was this slide, and that what is a managed alcohol program. It's a harm reduction method. There's a number of clients. Some of these managed alcohol programs are either outreach based, which is what we do. We don't have a residential site yet. We are hoping to get one in the future in which we would still do outreach cases, but also have a residential setting. And for clients of the program, they're given what is essentially prescribed doses of alcohol that are consistent with how much they need to prevent withdrawal. And they get the doses several times a day. Most residential programs, you're looking at maybe, you can get a dose either every hour, every 2 hours for a max amount of doses per day. What we do is 2 to 3 doses every day, normally 3 if we're starting someone off. Some folks only have 1 drop a day. And I would say that most of our clients right now get a drop in the morning, and then they also get a drop in the afternoon. And it's for clients that are, they suffer from severe alcohol use disorder, that they've been drinking for years. We do have some folks that are only in their late 20s, early 30s, but they started drinking when they were 10 or 11. And so that's still about 20 years of pretty chronic and severe alcohol consumption. And most of our clients are, to have severe alcohol use disorder, all axes of your life are often affected. So whether it's your housing security, your food security, your relationships to yourself, to your community, to your loved ones are affected. A lot of our clients have other health conditions, whether mental or physical, but haven't had a way to address those issues. So getting them connected as well from the beginning. And a lot of our folks have not been able to access high quality of care because they are often high emergency services users and are labeled as frequent flyers, or folks that are requiring too much in terms of care. So it's folks that often have really high needs, and at the basis, to make sure that they're intaked properly into the program, it's someone that is quite a large daily drinker, and they do have severe risk of withdrawal symptoms, whether it's seizures or delirium tremens, DTs. If they were to try to quit drinking, whether cold turkey or as a slow reduction. So its MAPs fall under harm reduction in the sense that methadone maintenance or safe injection sites or needle exchange do, in that they're folks that want help with their drinking, whether they don't necessarily want to reduce, but they want to drink in a more managed way. Or there are folks as well that do want to reduce very slowly over time. They might have tried going to treatment or detox several times with no success. So we definitely work with a lot of folks that have different goals, and whatever their goals are, we'll work with them. We do also work with some folks that are, they still live independently in community, but have very low capacity and might be quite street entrenched and have a long history of DTs or seizures, or also have some pretty severe traumatic brain injuries on board, in that they still really want to drink and they don't want to quit drinking, but they also have difficulty managing their consumption and are at risk of going into seizures if they don't have any alcohol on board over 12 hours, right? So it really depends on the type of person that we're working with, but we'll work with pretty much anyone as long as they fit those criteria and have some intention on either wanting our help or trying to reach whatever their goals are. So we're very open when it comes to following goals. The benefits, and this is like the benefits on paper, but it's also benefits that we're seeing are that there's often maintained housing, and that's something that we work pretty hard at, in whether it's getting folks attached to some degree of financial management, or there's, there are a lot, at least in our area, there's a lot of potential funding, whether COVID-19 related or not, that folks are definitely eligible for to protect their funding, or whether it's just having part of their, if for clients on PWD, it's pretty, so persons with disability, it is quite easy to have their rent automatically paid out of that, so they don't have to worry about that anymore. So housing being a big component right now. The folks that we have on our list currently are all they are all housed, though some are definitely at kind of a gray area, and that housing is at risk most definitely. But we do also work with folks that are either less housed or couch surfing or unhoused. We have agreements with the Salvation Army, which is the only shelter in town here, and that we can provide alcohol to clients if they are staying at the Salvation Army. The other agreement that we have, and that one of the benefits of managed alcohol programs that is seen across most studies, is a decrease in law enforcement interactions, but a lot of our clients definitely have a history of either ongoing or more acute law enforcement interactions. So the RCMP here has agreed to let us provide alcohol if the client ends up in cells, and that the client can self-disclose that they are part of the managed alcohol program, and then they'll call Cathie or I, and we can go and make sure that they get what they need while they're in cells. There is historically a number of withdrawals and acute dangerous withdrawals in cells that had happened. So to try to prevent that from happening again, it's definitely up there.
Yeah, so one of the links that I provided is a coverage from Global News that also covers well, part of it is an interview with Corporal Chris Voller, who, in conjunction with us developing our managed alcohol program, he was also developing a policy with RCMP. And this was, he started locally, of course, with a local detachment to draft up policy for our managed alcohol program to be able to provide alcohol drops to people in cells. And he was bringing it to the RCMP to make it a national policy. And so that's still moving forward. So we can also provide a copy or a draft of that document as well for anybody who is interested in also pursuing it locally in their own communities.
Yeah, definitely what we have noticed, because we're just turning one shortly for the program, but the Canadian Managed Alcohol program study is a pretty vast network of folks that are doing maps across Canada, but also across the world. And in, I think, an effort, like all of us, like I said, really enjoy sharing the things that are being created so other maps can use them. So stuff like, memorandum about alcohol in cells for MAP clients is something that we've shared with them, but we're happy to share that with others too, because once it exists in one place, there's precedent for it to happen somewhere else too. for the next, like for the rest of the benefits, and this is stuff that we are seeing for our clients as well, and that there's improved well-being and quality of life. It's obviously a pretty intensive program, and that clients do have to agree to see us several times a day. We do work with a couple clients that actually are at a point where they're not drinking anymore, but they still need and want ongoing support on a daily basis, whether if it's for, you know, medication management or food security, those type of things. So because recovery is never linear, we also continue to see those clients because it's still harm reduction in the end, whether they start drinking again or not. Those are some pretty strong bonds that we've created with them. Otherwise, you know, reduced frequency or quantity of alcohol use. Most studies for MAPS might show that, in particular for people that are daily drinkers, they might drink more days out of the month if you're on a MAP, but it's actually less drinks in the month, in that everything is more spaced out. You're not having periods of acute withdrawal with seizures. You're not having to enter either by emergency health services or into the hospital for DTs. So it's a lot more managed for our clients in that reduction in severe withdrawal effects. So whether it's someone that has been drinking for so long and has had so many seizures that their seizure threshold is so much lower, and they've actually developed a low-grade epilepsy, so a low-grade seizure condition because of the chronic drinking, which is unfortunately a possibility. Getting them on seizure meds and then making sure that their alcohol consumption is much more managed is definitely two of the big ways that we try to counter that. We so far, the clients that we have had might have a history of non-beverage alcohol consumption, but none of our clients right now are drinking non-beverage alcohol, and that they're all drinking the alcohol that we provide. Most of the agreement that we have with our clients is that, you know, we will provide the alcohol. So it's an agreement to not drink more than we provide and not share the alcohol that they're given. And, you know, whether it's trying to find that proper dose at the beginning, so increasing or decreasing, it's really up to the client at that point. But it's kind of, we'll do the purchasing of the alcohol for them, and we'll do the drops and work at it from that way. And then again, that decrease in alcohol-related harms, and that there's less, either whether it's social, financial, physical, or mental. A lot of the clients that we have, again, have had really poor service from other healthcare providers, or have had difficulty accessing service with healthcare providers. So all of the clients that we intake into the program are we make sure that they have an attachment to a family doctor, and we, you know, there's, after they get through our managed alcohol program intake interviews, then we'll hook them up with a family doctor and make sure, you know, if there's medications that they haven't been accessing, or there's conditions that they have that haven't been treated, or there's referrals that need to take place. One of the big ones being to mental health and substance use services to make sure that they get counseling or psychiatry access. So those are two of the big ones, but after that, we make sure that we help them get to their appointments, appointment reminders, whether it's like us, since everything's on phone now, you know, staying at their apartment and doing the call with them. They're free to use our phones if that's the case, and that a lot of people also still don't have phones, right? So making sure that those needs are met, and then hopefully a decrease in emergency health services or law enforcement interactions. For most of our clients, if there is an emergency health service access point or a need to call EMS, it's us that are making it, and that we see them so frequently that we're normally able to notice if something is going wrong, or if there's some degree of crisis brewing. So making sure that we make that call, and then we will go and sit with them in eMERGE to make sure that they access the type of care that I would hope that they access. There's historically, I mean, the Port Hardy Hospital is quite known for its racist care. So we make sure that as advocates, we go and sit with them until we make sure that they get what they need. And that's normally, I mean, there's regular physicians with the Port Hardy Hospital, but there's also a lot of locums that have less of an understanding of the harm reduction services that are offered here. So making sure that, because with some doctors, you know, if you have an alcohol use disorder or substance use disorder and you go to emerge, then they automatically decide that the best thing for you is to go into detox right then and there without any like overt consent from the client. So we make sure that things like that don't happen. If they're admitted into the hospital, then we can also do managed alcohol programs in the hospital for them. So we'll do daily drops and daily visits in the hospital as well, if that's needed. In terms of, you know, MAPS being different in that it's really a harm reduction program as opposed to a treatment program, and that will work with clients towards their goals, whatever their goals are, and however fast as they want to proceed. If their goal changes, that's fine with us as well. If they have new goals that come up, or they want to adjust their doses, or they want 2 drops instead of 1, or if they want to go into detox and they want to, you know, they want to stop the managed alcohol program, that's definitely, we'll work with them for however long their needs require. And
so we require our participants to also pay half the cost of the alcohol. So we really work with them to figure out what is their alcohol choice. The benefit of our program, we've had the luxury of being able to do that. Some programs only provide one specific type of drink. And so we've been allowed to anyways at this point. We've been able to work with our folks to provide them their drink of choice at the moment. And so it's familiar to them. So the buy-in has been easier that way, to be able to still provide them with a drink that they're familiar with, and then work with a dose that's appropriate for them to then maintain.
One of the big things that we're definitely happy for, and that all the physicians at the Port Hardy Primary Care Clinic, and again, these are the same physicians that work at the hospital here, they have received extra training to kind of cover the FDA-approved medications to help with cravings. So, you know, we're not using the second one here is disulfiram, and that is no longer something that we are using. I mean, us as a MAP, we've never used it, but that's kind of when a lot of clients are asked if they're interested in medications for craving, disulfiram is like the big one, and that they think that this is something that they'll have to quit drinking for, and that if they do drink alcohol, they're going to get sick and it's going to make them really nauseous and vomit. So that's kind of the old school way before some of the better medications have come up and have just demonstrated much higher efficacy. And there's just so much more evidence to support those ones being made. So stuff like disulfiram we're not using. And that is a bit of a learning curve for a lot of clients that have worked through this system and have been struggling with either alcohol use disorder or substance use disorder for, you know, over time. And that at some point, if someone has tried to get them to stop drinking, then disulfiram is probably the one that they've been offered. And with disulfiram, essentially, if you drink alcohol and disulfiram, then it's going to make you really sick, so that there's no joy from drinking alcohol anymore. But it's also for people that do still want to drink alcohol in a managed way, disulfiram is not the way to go. The big ones that we're using right now is whether it's topiramate or naltrexone or gabapentin. There's a lot of worth to these meds, and that they're pretty low on the side effect scale, but they will, for clients that do want to try a medication to help reduce their cravings over time, they definitely do tend to, for the clients that we have that are on these medications, of course, because some people don't want to take them, that's totally fine. But for the folks that on our program that have started them, they do realize that over a period of weeks, as they get to kind of a more stable dose of something like naltrexone, they are seeing that there's a reduction in cravings overall. So they're still able to drink and they're not going to get sick when they drink, but their brain is going to kind of remind them less that they want to drink and that they're going to have fewer cravings over time to drink. So for folks that like really have an intent on reducing their alcohol intake, whether short-term or long-term, that can be something that's quite beneficial to them. So naltrexone being the big one that we'll try. Obviously, if someone is also using opiates, naltrexone wouldn't be the best one for them, but there's other medications that are also good that can be opted into. We do see a number of clients that have other, they like to use other substances as well. So we do have a huge stock of harm reduction supplies, and it's not like we're not going to not take someone because they also smoke crack. Totally fine. If you want to have, clean pipes or clean syringes when we do your drops, just let us know and we'll drop those off as well. If someone wants to work on those goals or, they have goals of quitting other substances at the same time, we can talk about that, but it's definitely, we really do try to meet the client where they're at and work on whatever it is that their goals are, as long as in some way we can kind of agree on that us providing the services and that it's so intensive, there is going to be some harm reduction there. And definitely, yeah, the intramuscular one is not one that we would do. So the oral naltrexone is the one that most of our clients would opt for as a first line one. So for a lot of our clients, medication compliance or medication management is something that they're trying to work on. And historically, if they have had the ability to maybe access psychiatry services and that they have an anti-anxiety med that they want to get started on, but they're just not able to go to the pharmacy, remember to pick up their meds, or remember to take their meds daily. For most of our folks, we will either give them daily drops for meds as well as their alcohol. But also if they want us to just pick up their meds for them, drop them off once a week, we can do that as well. So it really depends on the client. So going back to kind of the origins of the Gwa'dzi Managed Alcohol Program, and this is still to this day what we have decided on, is that it's a managed alcohol program. As a program, we're eligible to anyone in the Port Hardy or Gwa'dzi area. So there's the neighboring Kwagalt and Quatsino nations, which are maybe 10-15 minute drive outside of Port Hardy, depending on how fast you drive. But otherwise also Gosal Nakokto community members, and that's whether you're on reserve or you're off reserve in town. We will also see non-Indigenous Port Hardy region residents. And as long as the client is interested in reducing or maintaining or working around their alcohol consumption in a less harmful way, we'll definitely agree to work with them. For clients that, there's still a lot of folks that are not folks that want to work on their drinking. And that is, something that I think some of the ideas at first and some of the potential intakes that we've received are kind of like, oh, so-and-so like is a drinker, like he definitely needs this program. But you really have to want to access the services. You have to want to hang out with us several times a day. We started off the program working Monday to Friday, and it was just Cathie and I. And so we do like the drops every day, the medications, we label everything for the weekend, and clients were having a lot of success over the weekend. And then it would over the week, yes. And then over the weekend, it would just all descend into chaos, and they would have just so much less success over the weekend in managing what they were given. So we started working 7 days a week, which is not something I would suggest to many people, but we did it until we could make sure that we got funding from Island Health, which did take a while. And when Island Health decided to kind of pony up their funds, and that it did take some convincing from our health director again to convince Island Health that they also are responsible for providing services to Indigenous folks, not just FNHA. And that we also service folks that are non-Indigenous as well. So eventually they agreed. And so we have at this point another registered nurse as well, another outreach worker. So we're a team of 4. We do alternating shifts, but we are 7 days a week now. We operate from 8:30 a.m. until 6:30 p.m. with the occasional emergency after hours, but by and large, and kind of working really firmly with our clients in that if they do have a crisis after hours, then they've got, whether it's the mental services crisis lines or whether it's EMS. We've worked really hard to, I think, have the EMS services at least somewhat more accountable to our clients and making sure that they provide a standard of care that we expect of them, whether it's by EMS or when they get to the hospital. So
it's a lot of we did a lot of community partners working with them, like, really meeting with them and making sure that there was a good understanding about our program and also a good understanding of what our clients' needs are as well. Because a lot of folks that work EMS they know these particular folks as just, drinkers downtown, and they're often just seeing them at their worst when they're passed out, unconscious, hard to wake, hard to rouse, and they're being difficult. And so really working with the EMS folks especially to see them more as humans, and that they deserve, proper care, and that because of our program, they're not seeing them as often, and they're seeing them downtown in a better way, in a better state of health even. So really working with our partners, having those conversations, having regular meetings so that we're connecting and maintaining relationships with our community partners, because there's a revolving door a lot of times with workers up here in the North Island. So we have new staff at the different services too. So we connect with our community partners on a very regular basis so that we have our information out there. They know that they can always contact us. And our extended hours till 6:30 in the evening has really allowed us to provide that extra service. Many of the emergencies that happen with our folks happen past 4:30. So when it was just Alexa and I, we were ending up, racking up the overtime hours because some of our folks would be brought up to emerge after 4:30. So then we're sitting there providing advocacy and support to our person. And so having the extended hours really is important. And we haven't had too many of our folks go, need us past that. So if you're thinking about developing a program, having those kind of later hours to provide the support at the hospital is probably a good idea to kind of factor in.
So how it works for essentially getting into the program, in that either a community partner or a doctor will refer to GMAP or a client will self-refer. We get a lot of families reaching out like, hey, can you talk with so-and-so, and we'll kind of say like, here's my contact info. If they are interested, they will need to contact us. I can take a referral from a potential client themselves. We get, at this point, we've plastered our contact information at every kind of health meeting point in Port Hardy. So, you know, the nurses in Emerge or the doctors in Emerge will know to contact us if there's someone that, you know, has come in this month in withdrawal 4 to 5 times already. It's been, I think, a lot easier for us to be accessible to clients, and that we'll take referrals from anyone, as long as they want in.
Yeah, at Christmas time, we also all got, like the whole agency got team jackets and with our programs on the side. And so sometimes after work, I've gone downtown or I've gone to the grocery store and I've been stopped and asked about the program just right in the middle of the grocery store in the aisle. How's it going? Tell me more about it. I'm like, how much time do you have? So really good promotion, and now everybody sees us in our jackets, and we're always at the liquor store, and and folks congregate around the liquor store a lot too, in that part of downtown. So when they see us with our jackets on, they know who to approach. For to ask about the program, and we'll have some people just come and ask us, and some people tentatively say, I want in the program, how do I get in the program? And we tell them this is when we're available, have a conversation with us, and then some of them follow through and some of them don't, just whenever they're ready, right? We're not there to push our program on people. And yeah, and I tell them right off the bat, it's a huge commitment because we see you once a day at least, twice a day most of the time. And for some of our folks, we do see them 3 or 4 times a day, depending on how their health is at the first checkup, right? First check-in of the day. Sometimes we will have to go in and adjust the dose of the drop at the time too, because if they're not doing well, or for some reason they've decided to purchase extra and they are consuming extra on top of what we drop, we can't give them the alcohol that we're providing because it's a prescribed dose, and if they're already intoxicated, that's not in accordance with what our commitment or the commitment to our program is. And we have those clear discussions. I think the relationship between us and our participants is so key, because it's a communication dance with us. Every time we check in, there needs to be a huge amount of trust built. I think one of the big successes that we had in starting the program is that, I mean, I've lived in Port Hardy for over 40 years, and I know a lot of folks here. And then Alexa, working in community as the community health nurse prior to starting our program, also had created these relationships. And she and I had worked with mental health prior to starting with Gwa'dzi Managed and working in harm reduction and with the intensive case management team. So really already working with a similar, that population, but the relationship building between even the people that will access the service is huge. It's really important as well.
So after we get through the kind of referral, however it happens, there's an intake interview with either Jessie or I, so with an RN. We go through their whole, what their goals are, what their drinking's like. If it seems like this is a client that really wants into the program and they fit that, the criteria, then going through their drinking history. And after that, we will book an appointment with a doctor. In BC, you don't need a doctor to prescribe alcohol. An RN can do it, but the clients that we're taking in, we found are like quite high need in a lot of different realms, and there's often maybe years of medications that have been missed, or there's infections going on, or there's referrals that need to be made other than that. So we have found it to be really beneficial to do like a full head to toe assessment. We'll get bloods and labs if the client wants to, obviously. look at medications, look at their history, and get them attached to a family physician. That way, if they do end up in emerge too, it is always best if there's a family physician attached to them. We figure out what their dose is, and that's basically based on standard drinks. So University of Victoria has a really good standard drink calculator. That is what most MAPs use, and it's available online to figure out how much the client would need during the day. Most clients that drink quite a bit, or most people that drink quite a bit and that have an alcohol use disorder and are living with it, know how much they need to prevent withdrawal at a minimum. So, you know, we don't necessarily want to be at the very base of the minimum, in that if they miss a drink, they're going to go into withdrawal, but maybe 20% above their minimum, so that it's a dose that they're comfortable with. And if they want to reduce, we're only going to reduce as fast as they want us to. So, for example, if someone is starting off with 16 beers a day, and a month in they want to know if they can cut down by a beer or two in a day, then we'll work with them for that. But we're not actively questioning folks when they want to reduce. If they are working towards a reduction, we'll just go as fast as they want to. So they get their drops and their meds. We do the wellness checks with them. Most of our folks we have now receiving food hamper baskets either weekly or monthly from the Harvest Food Bank here. So we'll pick those up and drop them off with the clients. For our folks that have issues either purchasing food or accessing food for a variety of different reasons, we'll do daily drops of food for them that they might pre-purchase. And so it really depends on who the client is and what their needs are. But there's definitely, you know, the wellness checks are key. We'll do street outreach with some of our clients that are regularly spend most of their day downtown or unhoused, and maintaining those relationships, as well as regular communication with other teams if the client wants us to keep in touch. We do have a lot of referrals that we get from mental health and substance use that Island Health operates in Port Hardy. So if a client is okay with us talking with them, and you know, most of those clinicians are folks that we've got working relationships with anyways, and we have worked with in the past, so we can check in with them. If they want to talk with counselors from GNN, we'll make that happen as well. If there's kind of a higher level of mental health services that they require, and that there's maybe a psych referral on board that needs to happen, we'll make it happen. So it really depends. So this is kind of, and at this point, you know, because we have Jesse as well, so we'll have our work cell phones and we've got our work emails, and we can put our contact info. Well, I think Cole's got that anyways, so that can be shared. But we, you know, if there's folks that want to start managed alcohol programs and want to shoot us an email, and we can book a Zoom or a regular phone call. We also do regular phone calls. Whether it's email questions, we're definitely happy to kind of pass it forward, and that we had a lot of help in getting this program started at the beginning. A lot of other MAPs be so open with us, and you know, definitely something that we would want to as well assist in. Yeah. So if it's definitely, you know, you don't necessarily need an RN or two. This is the program that we wanted to build. So it's beneficial for our program. There's MAPs that just are kind of peer support workers, outreach workers. There's MAPs that are residential. There's MAPs that are really community-based. There's MAPs that only, you know, don't even do necessarily daily doses, but they'll go around and trade out non-beverage alcohol for beverage alcohol. It really depends, and that, you know, depends on the types of clients that you're working with, or that the type of community that you're working within, and what their needs are. This one is like pretty suitable to Port Hardy. We do have big goals in terms of also having some type of residential program, and that there's folks that are chronically unhoused here, but without housing, it's some folks just kind of live in the woods too. around Port Hardy. So it's difficult to access some people. We can't make sure that we see them every day. So having something that might be, have a residential wing as well, whether for stabilization or for long-term intakes would be good. We're at a point in Port Hardy where there's no real, there is actually no medically assisted facility here for anyone of any age. And I think we've only got like a couple senior beds in the senior building. So when it comes to housing, it's really difficult for folks with any type of medical or severe mental health need to access housing, regardless of the age.
Well, housing itself is really difficult to come by because we had a fire in one of our bigger apartment buildings, and it really displaced 40 tenants, like families and single people at the time. And so many of them have found housing. Some have found housing in Port McNeill, which is about half an hour away, but that takes them away from their family, from their Port Hardy family. And many of those folks that were displaced are couch surfing as well, or living in an apartment building that's very rundown and should not be operating. But it's very difficult to find housing here as well. And so we're really fortunate to have the Salvation Army. They have 5 all year round shelter beds. And then in the wintertime, they have their extended 6 more beds on top of that for the extreme weather shelter. The other piece that I wanted to mention too is that with our growing regular participants of the program, we also keep some time to be able to intake on a short term anybody who has to isolate due to COVID. And that was the understanding or the agreement right off the bat that we would do that. When COVID first hit up here, there was an outbreak in Alert Bay, for instance, and there was 30 people that were identified that were tested positive. The community of Alert Bay did an amazing job, and the Numbees First Nations did an amazing job of containing that outbreak. But they had to have, there were a couple of people that needed an emergency map at the time, and there was nothing developed. So they kind of pieced it together. Mental health did the supports, RCNP were there 24 hours to do watch. I'm not really sure how that all went down, but that also then gave us the kind of a push to be able to ask for funding for this program because of the limited resources at the time for anybody who would have to isolate for COVID.
So that's kind of our base spiel. I do see that there's some questions though. So Cole, do you want us to just start answering some of the questions up, and you can let me know if there's some that we've missed?
Oh, I just wanted to also say at the beginning when we were when Dean was going to FNHA to request funding, it was also with the support of the health directors of the other two nations, the Kwa'dzi and the Gwa'dzi. So Marie Hunt and Jen Nelson, the 2 directors, were very supportive of the proposal that went to FNHA. So it's with the support of the nations that really got this going, and we're happy to be able to provide this for the community.
Awesome. Absolutely. Thanks very much for walking us through that, guys. I really appreciate it. It's inspiring to see all that you've been able to achieve in less than a year. That's great progress. So Alexa, we do have quite a few questions that have come in, so I'm going to do my best to kind of walk us through them.
Okay.
Step by step here. So we've had a few questions touching a little bit on liability. one individual, Aaron, asks, we found that there's tons of stigma and a hard no when it comes to ideas of managed alcohol, specifically on liability. And then we had the other another question come in. Again, I've had Indigenous communities ask about where does the legal accountability fall and what does that look like? So if you could maybe walk us through, if possible, what that looks like for you guys.
I mean, when it comes to legal accountability, what we're doing is providing harm reduction, right? We're not, we're supplying alcohol that you don't actually need a prescription for, that people can access on their own. And so the benefit to having, let's say, nurses provide the service like we do, chart on everyone. We see them as clients, we get them attached to a physician. Anything to do with medication would fall under a physician's accountability. The alcohol themselves, as long as you're providing a harm reduction service, something that the client is already accessing, there's, I think, like, the worry or the fear about liability is a lot bigger than the actual threat of legal action or liability. These are services like Managed Alcohol Program is also offered in hospital and has been for years. Like, a lot of there's maps that are 15 to 20 years old. It's just more so, I think, in more communities becoming open to harm reduction, and that map is becoming a bigger part of the conversation, just like safe injection sites, or let's say, I know in a couple spots in BC now, there's the clean drug supply machines that you can access literally clean drugs from. So these are things that folks are accessing already.
The BC CDC actually has put out a guideline on how to do how to develop a MAP program.
Yeah, so it's stuff that, is
is it the BC CDC? Anyways, I will send you the link to that guideline.
So it's the BC Center for Substance Use Research, BCCSU. And so they've got a big kind of how to do MAP. But it's stuff that, has been available for a long time. No one gets sued for providing alcohol to people that are already accessing alcohol. It's definitely, I think, as long as you know and that you have workers that stay within their scope of practice, and that we're following ethical codes. And the biggest thing I think that would be a liability is more so if you have workers that aren't protecting clients enough, or that they're sharing client information. There's obviously a lot of stigma with folks that that do live and walk with substance use disorders or alcohol use disorders. So let's say our client list, we don't have full names up in our office. The rest of the clinic doesn't know who is in our client list. We will only talk to other groups if we have the client's overt say so. So the client has to consent to any information being shared with anyone. Otherwise, if we have someone, maybe we just took on a practicum student who's she's a GNN community member doing her outreach support worker practicum, so getting consent from all of those clients as to whether or not they were okay with seeing her as well as us. So I think it's just like any other type of care being provided. There's you make sure that people that are starting a program, if they're either working for your nation or working for an agency somewhere, that they are like any other regular workers. They're going to follow a code of ethics. They're going to keep all information confidential. They're going to keep track of their records. And it probably would be an issue if I was actively dropping off alcohol to someone that is already clearly intoxicated. That would probably be maybe like a liability risk. But if you're if you're doing the work like you're supposed to and you're doing your checks and you're charting, for every drop we chart, and we chart if there was any symptoms of intoxication or any withdrawal symptoms before we do the drop. And if someone is heavily intoxicated, then we will check in on them again a couple hours later. So yeah, I think as long as you've got a good group of people, they're all doing the work that they're supposed to do and following something like, you know, a internationally available managed alcohol plan that BCCSU has put up, then you're going to be fine. I think that, you know, we definitely live in a world that is scared of legal action or legal liability, but when it comes to providing care to people, it's a MAP is really just like anything else.
Well, and we're using the alcohol as a prescribed medication in essence for our participants. So I think it's valuable to have a nurse, definitely, to be part of the team to at least oversee that piece. As well, like Alexa was saying, we also assist with medical or medication management, right? So again, having a nurse on the team, at least one, is really valuable for those kinds of pieces. And once the dose is set and medication is reviewed, it can be dropped by an outreach worker or community. Some MAP programs are actually peer led or peer. The staffing are peers, right? That have had training, peer training.
Well, yeah, if you have a MAP that doesn't have medical oversight, then don't engage in the medical aspect. That's all I would say. I really don't like MAPs to be gatekeep. They can definitely be done by anyone as long as the program meets the scope of practice or the abilities of the individuals providing the care.
Awesome. Thanks, guys. I appreciate that. The liability piece, yeah, it would be no different than anything else. And thanks very much for making that connection, guys. It's really, I think that people are nervous about it, but for sure, if you're following the plans that were set out and following proper code or proper protocol for charting and that sort of thing, it should be fine. A note to everybody that's listening along, we'll try and find the BCCSU plan for you. I'm sure that, is it posted online, guys? Cathie?
Yeah, it's posted online, and if you can't find it, like I've got it saved on my middle of my screen.
So yeah, front and backwards, and developing our own program. Absolutely.
Awesome. So yeah, we'll try and find it for you guys and have it in the resources section for you to peruse later on if you're interested. So we have another couple questions here. The first one specifically, there's a question that came in on funding, specifically on how do you get buying alcohol funded, as I am anticipating or kind of reading between the lines on that question that might have been a stumbling block that other people have found in the past. Do you guys maybe want to walk us through that specific aspect of your funding, how that works, how you're able to apply for that?
Absolutely. So this is exactly how it has happened for us. So this kind of just applies to our specific situation and the funding partners that we have. So the funding partner that we have first and foremost is First Nations Health Authority. And so in terms of the purchases that we make for alcohol, they're coded under program supplies. There's nothing on paper that says that we're buying a large amount of alcohol on a weekly basis. It's program supplies, whether that's Gatorade or alcohol. We save all the receipts, and that goes to finance. We are, so GNN Health, it's a self-governed nation in terms of the health services here. So we get the funding pot. Finance deals with that stuff. We give all the receipts. It was easiest for us to kind of get a company credit card for the program, just to use a BC Liquor. But otherwise, like every month, I'll tally up what each client has consumed in terms of alcohol over the last month, and like with whatever the the costs are. So we save the receipts and then divide that by 2, and the client just pays half. And so we'll collect that as cash and use that for the next purchases until we have no more of their cash left, at which case we'll use the company credit card, saving all the receipts, giving them to finance. But
as far as like the, budgeting for the proposal, I don't think Dean at that point really knew what the budget would be and just guesstimated an amount and to include in the proposal and then to be reviewed, right?
Yeah.
So far, I think we've been staying within that.
But FNHA did make it very obvious that we can't, like, there's to be
no attachment, no labeling
of like booze. So it's just program supplies. Island Health didn't even give us money for alcohol.
No.
So anyways, we're up for review at the end of this month. So that will, that's something we're going to be pushing for. I'm not sure if that's just because they were like, we want no part in this, or I'm not sure. I don't know how it works, but anything can be coded as anything, and technically it is a program supply and it's a legal substance that you can buy anywhere. So yeah, it's kind of honest discussions with funders is a big thing there. I think that, right now there's a lot of funding for COVID-19 initiatives. So if you can like waive that right out, that's always a good thing. There's a lot of harm reduction funding opportunities that are available with the opiate crisis. There's enough of these clients that might be folks that do also struggle with substance use disorders beyond alcohol use disorder. So really depends, but yeah, it's anything can be coded as anything technically.
Awesome. Yeah, honest conversations with your funders and kind of figuring out where they, where their comfortability lies on that. Good luck on your reapplying for funding or whatever it is at the end of the month. Hope that it goes well. So just moving right along here, the next question, which I thought was really interesting, comes from Alexandra. Were peers or folks with lived experience included in the development and now implementation of the program? And if so, how did you manage their perspectives?
So everything that BCCSU has put up and the managed alcohol program guideline that exists is one that has been part of the discussion with folks with lived experience of severe alcohol use disorder. So everything that comes up from BCCSU is pretty fabulous in that extent, in that so as the everything that's put out from the Canadian Managed Alcohol Program study has a lot of involvement from folks with lived experiences. So we took essentially these guidelines from other maps and from BCCSU and the Canadian Managed Alcohol Program study from like what has been developed right now that is both evidence-based and has been reviewed by folks with lived experience, either ongoing or past. And then built kind of the program that we have right now, which is by no means groundbreaking, just very convenient for this area and maybe new to this area, but maps were something that initially were very much created by folks with lived experience and created by peers, and then as a more grassroots movement. So I think that, like most harm reduction initiatives, it was all actually created by folks with lived experience, whether ongoing or historically. So we're definitely very thankful that all of that research that was led has been very much created with the oversight of folks with lived experience. There's currently a national coalition or committee for managed alcohol programs that's Canada-based, that's happening to, again, create more of this groundwork kind of guidelines so that MAPS again can become like more accessible and like more of a, I guess, a clearer path for people to initiate. And that again is like part, you know, frontline staff and workers and doctors and such, but there's also half of that committee is peer led and lived experience led as well.
We also have many of our hereditary chiefs and council members and community members who have been part of supporting the development and the initiating of this proposal and the rollout of the MAP program in our community. We have, you know, many of them have lived experience. So we've been so honored and fortunate that we've got their support.
Yeah, so I mean, for GMAP specifically, there's definitely taking, you know, everything that has already existed from MAPS for like the past two decades, but also modeling it from what the community itself wanted, and from both like hereditary leadership and elected leadership. So it's kind of a mix in that way.
Mm-hmm. Yeah, that's great. Thanks very much, guys, for pointing that out. I think that really highlights an important piece of this conversation, is that, you know, in order for these sort of community-based, community-adjacent managed alcohol programs to exist and to thrive and to do the work that they're supposed to do, they have to be supported by the community. There has to be buy-in from the community. Otherwise, it's just not, you know, you're not doing the work that you want to be doing. Or
you really come up against a lot of resistance. Mm-hmm. And a lot of folks will, you know, word travels fast. And if people aren't happy or people are not supportive of the program, the word will get out and it won't be supported.
Yeah.
And won't be, you know, people won't access it.
Mm-hmm. Yeah. That's awesome. Thanks very much, guys. So we have time for, you know, a few more questions, one or two, maybe more. We have one more Q&A question. If you have any questions, by the way, for Alexa and Cathie, please put them in the Q&A or the chat. We'll try and get to them as soon as we can. But I had a personal question, and it's kind of riffing off of this piece, which is, can you tell me a little bit more about some of the, you know, the growing pains or some of the things that you have encountered, some barriers that you guys encountered, particularly starting a managed alcohol program in a community that didn't historically support harm reduction programs, as you had mentioned previously, Alexa? Was there any like specific event or barriers that you guys encountered and were able to overcome that you think might be, you know, good advice or a good story for those that are kind of listening in and thinking about starting their own program?
I think that, yeah, so this is something that's ongoing and something that we come up against on a daily basis. And it's that there's a lot of racism here. And with like a lot of overt racism is definitely an association with Indigenous folks as being somehow, you know, tied to the alcohol that they drink, and that there's a lot of stereotyping of folks with substance use disorders that are also Indigenous. And so that's something that comes up on a daily basis. As a white person, I do try to bring it up very loudly when I see it, in particular with my peers, or if I'm like sitting with a client in Emerge, waiting for them to be seen, or waiting for them to receive the care that they should be receiving. So I think that, you know, from our program anyways, a lot of it is bearing witness to that and advocating for our clients. We put in complaints a lot. Like, I organize meetings with, as much as possible, anyone that will listen, and in order to, I think,
address
address it, but also to name it, right? So it's very obvious that there's a lot of stereotyping, there's a lot of racism in Port Hardy from the white population, and it affects the people that provide care in hospitals, especially if they're already tired and burnt out. I don't know, it seems to be quite easy for them to turn to racism. So it's very unfortunate. It's something that I think we come up against very often. I think that there's a lot of care providers that are used to doing the bare minimum for clients because they assume that they're not being watched. But we do our best to watch and to be able to, I don't even know, but if it's...
Well, we do the best we can to advocate for the best service to our folks, right? Our participants aren't always, they're not used to getting treated well, unfortunately. And so they go into emerge or into a different service resource in town with already their backs up with an attitude of they're going to say no or they're going to reject me. So we're trying to change that culture. We're trying to provide support for both the staff of whatever place we're going into and for our participants so that an actual service, a valuable service can be provided to our folks.
I think too, I mean, from a community basis, even if historically the community wasn't so much into harm reduction, and that's definitely the result of colonization, like straight up. So it was, I think, a big reminder during the COVID, like the initial COVID crisis, and that everything was done very openly, and that elected leadership and hereditary leadership were having discussions, and it was framed to all families that something like a managed alcohol program was something that was harm reductive in nature, and we do have to care for our community members that are struggling, and there's a reason that they're struggling, and it's what's been done to them. So
we still have a few, well, there are definitely still community members that don't quite understand the concept of harm reduction, and it's been our engagement and participation with our program that more conversations are being had with extended family as well. So a better understanding of severe alcohol use disorder, for instance, and how it actually affects their family member and how health is affected by their severe alcohol use disorder. And then the concept of the managed alcohol program. And so it's a slow kind of spreading of information to extended family of the participants. So sometimes we get feedback saying, well, it's not working. They're drinking every day. Well, yes, they are drinking every day because we're providing alcohol every day. But this is why. So it opens up these conversations to be able to then have a fuller, giving people a fuller understanding. And it shows people that we're approachable too, to have just those conversations, that that if they have any questions, and we put it out there, if anybody has any questions at all, information gathering about our program, about what we provide, about what it is about the alcohol, because people see us every day, but we're not just providing alcohol, we're providing a health assessment, support for medical appointments. We're providing medication check-in, even like follow-up. Is this working for you, right? It's a conversation every day.
Yeah.
Several times a day sometimes.
Several times a day, yeah. Awesome. Thanks very much, guys, for that. I appreciate that. And I think, as much as it is an ideological difference, let's say, for some people, I think it's also just an exposure thing, Maps have been around for a long time, as you said, Alexa, but maybe they haven't been as widespread or implemented in the settings in the areas that we're talking about here. And it's a matter of time. The good work that you guys are doing and continue to do is only going to further help that the effectiveness of harm reduction approaches, particularly as it relates to managed alcohol programs, continue to grow. So I, for one, thank you very much for all the work that you guys have been doing there for the community. It sounds amazing, and thanks very much for coming on here. We have one more question, and that came in from Natalie, and she just wanted to know, or sorry, they just wanted to know, how do you manage the workload and care for yourselves at the same time while kind of living in the community? You know, you live, work, and breathe and play with and around all these individuals. So how do you manage that balance?
Well, so our rotation is really cool because
now that
we have one, you know, actually, I enjoy my job. I love doing this work. So going into it, coming to work is not even like work. It's very enjoyable. I love seeing our folks every day. The relationships we have created with our participants have been, they're like family. And so, yeah, we do see them every day, and then we see them in community. And it is a dancing balance.
I would say that Cathie and I have a very unhealthy work-life balance. The best thing that you can do is be prepared and have you have enough staff to start the program, so you don't start the program without, like us, in like assuming that you can make this like a 5-day week thing. It has to be 7 days a week. People need daily support, sometimes several times a day. So you've got to have, you know, you can't do it in a silo. You need a buddy. So if you've got like 2 pairs like us, it works out. If it's bigger,
we're happy to share our schedule rotation, because we work. So our rotation is a 2-week rotation: 2 days on, 2 days off, 3 days on, 2 days off, and then every other weekend, the weekend pairs get off. And it's always a 3-day weekend. So there's a balance.
Get a therapist, I would say. I talked to mine, I just tell her everything's fine, but anyways.
We are 10 minutes away from the forest, to any trail, to a lake, to the ocean. We're so fortunate where we live that, you know, we go outside and I can touch the cedar tree and like just leave, you know, the heaviness of the day there. And I mean, I'm so fortunate that I have connections to quite spiritual people up here, that if I do feel heavy in my spirit, I'm able to access and just call them up and say, hey, I need a smudge, or I need a cleansing. And there are cleansing ceremonies of the Gwa'dzi that are starting to get rebirthed. And we actually also have a connection to our traditional healing worker that she did a pilot project last year, and I think she's still continuing, that she's using plant medicine, local plant medicine. So we have access to her too. So we do stuff.
Know what your boundaries are and follow them. Don't do like us.
Well, and we do keep each other in check, and we not check. We care for each other, clearly. we make sure that the burden isn't fully heavy, super heavy, that neither one of us or any of the 4 of us are taking on too much, and we share it. We share it around, and we have a great team. We have great communication, and if somebody can't see they're taking on too much, and I will go to them. I will outright go to them and say, take care of yourself.
Yeah. It's important to be surrounded by people that care about the work and about you.
Well, I think, I don't know, we're definitely very privileged, and that we also aren't dealing with even a quarter of the things that our clients are dealing with. And honestly, we've got, I think too, and having like the FNHA support has been really big. whether it's for funding, but also there's a lot of different initiatives that they've got going, and that we're going to be working with their team as well to get me and Jesse, our other RN, OAT certified, so that we could provide opiate agonist therapy or treatment to folks that want to access our program. So that's been huge as well, and that it's definitely less isolating if you have funders or if you have some like a big entity like First Nations Health Authority backing you up. It makes a big difference because it can definitely be alienating at times. So that's huge.
For sure. Just wanted to take a moment to highlight Natalie's response here. Thank you so much. Fantastic work. It's lovely to see you light up talking about clients and your humor. You are amazing. Thanks very much for your question, Natalie.
Thank you.
11:29. So we're right on the dot. I just wanted to take a moment here to say thanks very much, everyone that participated right up until the end. We really appreciate it. You engaging in the dialogue. It's been really great. Alexa, Cathie, thank you so much for taking the time. Alexa, coming in from your vacation, taking the time off to spread the word and to have a chat about your program. I really appreciate it. Coming up coming up next for the Learning Circle is the First Nations Virtual Doctor of the Day series. So we're going to have 2 sessions on that. The first one is next week. I want to highlight this because it's at 3 p.m., not at 10 a.m., not the usual time. So check that out if you're curious about the Virtual Doctor of the Day service and how that can impact you in your lives. Beyond that, again, Cathie, Alexa, thank you so much for your time here today, and thanks everybody else. We'll leave you at that. Have a great day, everybody.
Thanks, everyone.
Thank you.